Management of community-acquired pneumonia (CAP) involves several steps, including diagnosis, determining the severity of the illness, and choosing appropriate treatment. The following is an overview of the approach to managing CAP. 1. Diagnosis. Clinical presentation. Symptoms often include cough, productive or non-productive, fever, chest pain, and difficulty breathing. Physical exam. Auscultation may reveal crackles, decreased breath sounds, or bronchial breath sounds. Chest X-ray, a key diagnostic tool to confirm pneumonia and assess the extent of lung involvement. Microbiological testing, blood cultures, sputum gram stain, and sputum cultures may be performed, especially in severe cases or hospitalized patients. 2. Severity assessment. Clinical decision tools such as the CURB-65 score or PSI, Pneumonia Severity Index, can help determine whether the patient requires outpatient treatment, hospital admission, or ICU care. CURB-65 criteria, each criterion scores 1 point. Confusion. Urea greater than 7 mmol/L. Respiratory rate greater than or equal to 30 breaths per minute. Blood pressure, systolic and LT, 90 mm Hg or diastolic less than or equal to 60 mm Hg. Age greater than or equal to 65 years. Scores. 0 to 1, outpatient management. 2, hospital admission. Greater than or equal to 3, consider ICU admission. 3. Empiric antibiotic therapy. The choice of antibiotic depends on the severity of the disease, patient comorbidities, and local resistance patterns. Outpatient treatment. Previously healthy, no risk factors for drug-resistant pathogens. Amoxicillin or doxycycline or a macrolide, for example, azithromycin or clarithromycin, if local pneumococcal resistance to macrolides is low. With comorbidities or recent antibiotic use. Combination therapy with a beta-lactam, for example, amoxicillin/clavulanate, plus a macrolide or doxycycline. Monotherapy with a respiratory fluoroquinolone, for example, levofloxacin or moxifloxacin. Inpatient treatment, non-ICU. Beta-lactam, for example, ceftriaxone, cefotaxime, or ampicillin/sulbactam, plus a macrolide. Alternatively, a respiratory fluoroquinolone can be used alone. Inpatient treatment, ICU. Beta-lactam, for example, ceftriaxone, cefotaxime, plus either azithromycin or a respiratory fluoroquinolone. If Pseudomonas is a concern, an anti-pseudomonal beta-lactam, for example, piperacillin/tazobactam, plus ciprofloxacin or levofloxacin. Considerations for MRSA. If there is suspicion of methicillin-resistant Staphylococcus aureus, MRSA, vancomycin or linezolid should be added. 4. Supportive care. Oxygen therapy for patients with hypoxemia. 4. Fluids and monitoring for sepsis, especially in more severe cases. Antipyretics, for example, acetaminophen, for fever control. Bronchodilators if the patient has underlying reactive airway disease. 5. Follow-up. Outpatients, patients should be re-evaluated if they do not improve within 48 to 72 hours. Inpatients, repeat clinical assessments and consider follow-up imaging if there is no improvement or if complications, for example, pleural effusion, abscess, are suspected. 6. Prevention. Vaccination, encourage pneumococcal vaccines, PCV13, PPSV23, and annual influenza vaccines to prevent future pneumonia episodes. The management approach must be individualized based on patient age, comorbidities, and local antimicrobial resistance patterns.